According to the Organ Procurement and Transplantation Network, more than 100,000 people are currently on the national transplant waitlist, with another person added every 8 minutes. Nearly 90,000 of the patients on the waitlist are seeking a kidney transplant. Each day, 17 people die waiting for an organ transplant, owed largely to the fact that there simply aren't enough donor organs to accommodate a growing number of people in need of an organ transplant. As a result, transplant centers have gradually begun to utilize organs from donors classified as increased risk, meaning the organ came from a donor deemed to be at risk of having recent infection with human immunodeficiency virus or viral hepatitis. Although a mounting body of research suggests these organs are associated with similar, if not better, post-transplant graft and patient survival compared to non-increased risk donor organs, a stigma remains surrounding the use of organs from HCV-positive donors. And although we are now equipped with the tools necessary to treat and cure most viruses transmitted through donor organs, this was not always the case, especially when it came to hepatitis C. The advent of direct-acting antivirals has transformed HCV into a curable infection, but the question still remains. Now that we're better equipped to manage HCV, are we comfortable giving this disease to people who aren't infected in the form of a transplant with an HCV donor kidney? This is Crisis Point.
We're always very hesitant to expose individuals to things they do not already have, but there's precedent in solid organ transplant. We already use hepatitis B exposed organs. We certainly know that CMV and EBV are diseases that we're willing to expose individuals to if they don't have baseline immunity. And this is because we recognize that these are controllable or injuries or diseases that don't impact the survival of the organ or the individual that gets it. But we were really nervous about giving hepatitis C organs away, and that is because previously Hep C was difficult to manage. Interferon increased the risk of rejection, and so there was a lot of hesitancy. Now that our direct-acting antivirals have established safety in our post-transplant patients, and we recognize that this is a disease that can be eradicated, we've become a lot more generous in using these organs.
Hepatitis C and kidney transplant has changed quite a bit over the past few years. Before, we didn't really have effective antiviral therapies, and so there were challenges to transplanting patients with hepatitis C, safety concerns. And then later on, I think it was more about more directed transplants. So patients who had hepatitis C infection or and that was detected were directed toward hepatitis C infected recipients. And so that played a role. And if someone had a hepatitis C infection and was seeking a kidney transplant, that could help them obtain a kidney transplant more quickly. Then as antiviral therapies improved and became essentially 100% efficacious or very close to 100% efficacious, at least in the trials, the possibility of transplanting hepatitis C positive or infected patients into hepatitis C negative kidney recipients, so people on dialysis or people on the preemptive transplant list, people awaiting transplant, became a possibility. So I think it's exciting that we now have a disease that we can cure essentially with antiviral therapy, where we couldn't before. Much the way, in a sense, analogous to HIV. Now that we can manage over time. Even more exciting, though, that unlike HIV, where the antiviral therapies have to be given usually lifelong. For hepatitis C, a short duration. In the MYTHIC trial, patients were treated for 8 weeks with antiviral therapy. They can usually obtain a cure, or virtually always obtain a cure.
Indeed, the MYTHIC trial provided a solid foundation for the concept of using kidneys from donors with hepatitis C virus infection. Preliminary results confirmed the safety and efficacy of an 8-week course of direct-acting antiviral therapy initiated in the early post-transplant period, and 1-year findings showed that opting in for HCV kidney transplantation can increase the probability of receiving a transplant compared to matched waitlist comparators, with continued excellent kidney and liver function. Despite this and other data confirming cure rates and excellent outcomes following HCV kidney transplantation, many continue to view this concept in a negative light.
People are slow to change, but we have a lot of data demonstrating that these organs can be used very safely. We do know that hepatitis C can impact kidney disease. And so you really want to make sure that the hepatitis C exposed individual has healthy kidneys, but that's going to be true for anyone, right? If you have a kidney donation from someone who's diabetic and hypertensive, those injuries can also impact that organ. After that, because data really shows that these organs work well and, transplant offers a significant benefit over dialysis, I think clinicians became much more generous. And knowing that you can eradicate the disease and that therapy is much more easily accessible, I think that really erased a lot of the additional hesitancy.
I think for the nephrologist taking care of the patient who's seeking a transplant, this is a real benefit that the patient has an opportunity to have a kidney transplant more quickly, more expeditiously, and have better outcomes, better quality of life, fewer complications.
Even if clinicians have come to accept this as a viable option, what ultimately matters most is patient perception and whether or not they're willing to accept an increased risk organ. Although some aren't prepared to take that risk, for those who are, the results can be life-changing. Between faster time to transplantation, comparable health outcomes, and no longer facing the burden of dialysis, for some, including Kirsten Uzardo, the decision to accept an HCV-positive donor kidney is an obvious one.
So I was listed at my local transplant hospital in my state for about essentially 3.5 years. I was on their waiting list. It's a very small transplant hospitals. They didn't do a large volume of kidneys. There really wasn't anything other than standard transplants that they would do. And after a while, they sort of recommended, due to the time frame I had been waiting, to consider going out of state and being listed in other states nearby, which isn't easy as far as, being away from the home, children, pets, everything that goes into that sort of thing. I would need to live in that state near that hospital for at least 6 weeks, even if the transplant went well. But eventually we were able to figure all of those details out. So we traveled down to Mayo Clinic in Arizona. And it was there for the very first time that I had heard they were now transplanting kidneys with hepatitis C.
Patient perception is different. And here I think that a lot of that is going to be how the clinician, quote unquote, sells that organ, right? If the clinician says, oh, we're going to give you a high-risk donor, we don't know a lot about this, it's experimental, patients are going to be really nervous about that. But if you explain that this is a eradicated disease, it's going to allow them to get a good organ sooner than they would have been able to if they were waiting on a non-hepatitis C exposed organ, demonstrate that the data really goes towards safety, and talk about the fact that, we do know that when you're getting a live organ from someone, that there is always going to be risk to that. You might have some other injury that you're getting exposed to that we've never heard of. I mean, that's just part of the natural risk to organ donation. We certainly don't give away things that we don't think are going to work, right? All of us are graded on outcome. And if you're going to give someone something that's substandard, that's certainly a bad idea for your institution and for your organ outcome. And so, I think that when we can convince or relay that we think this is a good organ, we think that this is a good opportunity, most patients are pretty accepting. I know that in our institution and probably in most transplant centers, we talk to patients before listing or at the time of listing about these extended criteria donors, so that when they get that phone call, you can let them know, hey, this is something we talked about. Remember, we talked about hepatitis C exposed organs, and we think this is a good fit for you.
Along with the patient education and the other information that they provide, it was also noted that there's medication for that. It's about, 98, 99% curable. So at that point, they did have me, if I was interested in something like that, sign a form to say, if one becomes available, please do call me. It is absolutely something that I would consider. I was listed here locally near my home for 3.5 years with unsuccessful as far as receiving a kidney. I was listed in another state that did go through the process of offering hepatitis C kidneys. 3.5 weeks later, once I was listed there, I received my kidney. So essentially, for me, it was a no-brainer. I mean, I didn't realize I'd get one that quickly, and there were a lot of other factors that went into that. But I really truly believe that was a lot of what also added to getting the kidney so quickly, just having that capability.
The benefit of a kidney transplant is what's important. If you look at the epidemiology, we can usually tell our patients that they will have a longer life and a better quality of life with a kidney transplant relative to dialysis in general. And I think that's probably the most important thing to emphasize. Another benefit is that they won't be taking antiviral medications for a long time. There will be a brief duration. So these medicines won't always be on their medication list. They won't always be asked about it.
So I was prescribed medication immediately. Mavrit, I believe is the name of it. It's an antiviral. And I was on also entecavir, which is another antiviral. However, I believe I would have been on that anyway. So long story short, immediately after transplant, you are on a lot of medications. So for me, it was just another one added to that. They did keep me on that medication for about 6 months, even though at 3 months when I was doing the follow-up blood testing and things of that nature, it was undetectable. It was deemed cured, but they kept me on it just almost as a precaution for a little while longer. So really, honestly, it was not much different other than having, in a good way, other support systems, other people to reach out to if I had any issues, because you're on so many medications and steroids and other things that really sort of take a while to get into your system. So it really wasn't that big of a difference from my other transplants, honestly. It's curable now. They've got it. It's everyone should be considering it. They really should. That versus dialysis, it was worth the risk, completely worth the risk.
Beyond patient perception, another factor impacting the uptake of hepatitis C donor kidneys is the stigma surrounding the virus, largely pertaining to misconceptions about how it spreads. This can be especially difficult for transplant recipients receiving an increased risk kidney. Even if they have come to accept the idea of receiving a high-risk kidney, that doesn't mean the people around them will agree or understand.
We would encourage patients to tell their clinicians about this, that they have received a hepatitis C infected kidney in the past, because I think it's important for care to be transparent and open. But on the other hand, I think it really shouldn't be much of a concern. And I think in terms of their social interactions, there's no reason that their friends or their colleagues at work need to know that they received a hepatitis C infected kidney. I think it would make sense to just say that they have a kidney transplant if they want to say that.
But for some reason, there was a little bit inside me that I didn't want to just run and scream it out loud originally. And I'm not sure why that is. We did have to be extremely careful because apparently it is very, very contagious. So I was very, very careful not to do anything that would spread the hepatitis C. So I think for me initially, it was almost a little more uncomfortable around my family or letting people know, even though I was careful. But eventually I realized, why, what difference did it make? It was curable. I'm cured.
I think that most of the time when you have something that starts as quote unquote experimental or as an asterisk, then the more you use them, the more we realize that those are just going to be a standard organ. Now, you're still going to have to consent individuals for anything they can be exposed to, or you're going to have to talk to them about the protocol to prevent disease once they get that hepatitis C exposed organ. But I think that it is going to be commonplace, and you're going to stop talking about these extended criteria or high-risk organs.
With the advent of direct-acting antiviral therapy has also come the rise of a new approach to organ transplantation, allowing for the safe and effective use of HCV-infected donor kidneys. Despite findings from the MYTHIC trial and other confirmatory data related to curative effects of these therapies and associated outcomes, ongoing stigma surrounding the use of these organs continues to persist and hinder the adoption of what could be a viable answer to the ongoing organ shortage crisis and the need for donor kidneys. This has been HCP Live Crisis Point. Thank you for watching.